Cost sharing has gone up enormously. So if you look, the typical individual policy now, private individual policy, has a deductible of over $1,000. Family policy would be $2,000 or more. That's up at least 50% or 100% over what it was a few years ago. And that's actually more money than the typical family has in the bank in cash. So if they're thinking about medical care that's going to cost $1,000 or $1,500, what they're thinking about is, okay, I better be prepared to pay that out of pocket, and I just don't have that money. That's one of the kind of surprising things about the 2000s is that employers responded to, medical costs. They had already kind of gotten rid of anyone who they could think of getting rid of on their private policy, but they responded by increasing the cost sharing for people who were on private insurance. And so you see a lot of high deductible policies, a lot of tiered or limited network policies, where in some circumstances you're going to pay a lot. And that's really shown up a lot. There are a lot of people cutting back because they believe that they just can't afford the medical care now. Actually became important in the 1990s. Pharmaceutical cost increases were always a big part of healthcare cost increases for quite a time. You had new drugs coming on. A generic drug might be very cheap, but a branded drug would be $3 or $4 a day. Insurers wanted to get people to switch from the branded drugs to the generic drugs. So what they started doing is pricing the branded drugs to the consumer very high compared to the generic drug. So you started off with copay plans where the generic drug might be $5 and the branded drug might be $10 a month, and now you're in a situation where the generic drug might be $5 a month or $10 a month and the branded drug is maybe $50 a month. In addition to that, they've gone to the individuals and said, look, you're taking this branded drug, there's a generic drug that's just as effective for people like you that's going to save you $30 or $40 a month. They would go to the physicians and do the same thing. The net effect is that the switch from branded to generic drugs has been enormous, and it's a very big part of what's happened, particularly in pharmaceuticals. IMS Health just came out with a report the other day showing that nominal drug spending in 2012 was lower than in 2011. That continues a period of very low growth. It predates Part D, but Part D sort of cemented that. And when people look at, say, the generic drug efficiency, which is what share of the drugs for which there are generic equivalents are being prescribed and taken on a generic basis, it's absolutely enormous in the US. And that switch has been a very, very big part of why prescription drug spending has fallen and thus overall medical spending has fallen. Some of the expensive drugs are being put onto Tier 3, or in the Medicare drug plans, they're being put at a higher cost-sharing level. That's probably one reason why they're not selling well. But also, I think the drugs are not as effective as people thought they would be. So, for example, you have a situation where you have a new oncology drug that maybe costs $100,000, $120,000 per patient. The physician's paying the money up front and then getting reimbursed down the road, so the physician's sort of out of pocket losing some money that later gets reimbursed, all of which is for a 3 or 4 week gain in survival that may not even be high quality survival. And so a lot of physicians in that circumstance are saying, you know what, it's just not worth it. Some of these are okay, but really we're just not getting enough out of it to go on a wide scale basis and use that. And so we're seeing that across the board. We sort of see the examples of the Hep C drugs. There was Zaltrap, which sold for twice the price of Avastin, but didn't seem to be any better. So Memorial Sloan Kettering said they weren't going to recommend it, and the price fell in half within 10 days or so. Other drugs like Provenge that haven't sold as well as people thought because it's of the difficulty of using it and the fact that the survival improvements just weren't as big. So as people had hoped. So I think partly it's the cost sharing and partly it's also the technology has not delivered what people thought it might have delivered. Growth rate of imaging has certainly slowed down. It slowed down in the middle of the 2000s towards the late 2000s, partly because there's only so much imaging you can do. There's only so much, if you've got head trauma and you're sort of imaging everybody once, you can image some of them twice, but you're just not going to do that much. But also, again, because people are facing relatively high cost sharing, And so they're asking about, do they really need it? And because more providers are getting paid on a bundled basis for things, and so they're under a lot of pressure to cut back. So you'll have both a bundled payment in some cases. You'll have insurance companies using radiology benefit management systems, which are kind of like the pharmaceutical benefit management systems, that are saying, look, this particular scan is not indicated by this and this criteria, so unless you can show me a criteria by which they're indicated, we're just not going to approve it. And the patient saying, you know, and besides, I'm not even sure I need this anyways. You've had a number of studies that show that people are getting way too much exposure to radiation, that it's a source of cancer in a number of patients. So all sorts of things are coming together to lead to less rapid imaging growth. Not so much a drop in imaging, we haven't yet really seen a drop in imaging, but a sort of flatlining of the imaging trends. Yes, they are. The two poster children for poor quality care in hospitals are hospital-acquired infections, which had been noted for a while and had been relatively constant, and just in the past couple of years have been going down, and readmission rates to hospitals, which again were noted, widely remarked upon. It was a number that was about 19% of Medicare patients were readmitted and within 30 days. And just in the past year or so, we've seen that rate decline quite substantially as the Medicare penalties have kicked in, and as that's been integrated in a number of guidelines for how we're going to judge hospital performance. And so both of those are examples of very healthy changes. That is, there's no evidence that, certainly the infections are a good thing, not that people don't get, and there's no evidence that people are being harmed by not coming back into the hospital. So those seem like they're very good efficiency improvements. It's really quite significant. You've got two different ACO versions, you've got bundled payment versions, and so on. What's less important is the acronyms on any particular program, whether something is called an ACO program or called a bundled payment episode demonstration program. None of that matters. What matters is that what's taken root in a lot of American healthcare is the idea that the payment system is changing into one where moving away from you make money by doing stuff to you make money by treating people efficiently, well and efficiently. And that change, which has been promised and which we're in the process of carrying out in both the public and private sectors, is immense. That's what leads hospitals to say we ought not to have readmissions, or we ought to cut them back as much as we can. Leads doctors to say, you know, look, maybe I don't need an image here. Let me think about what drug regimen the patient's on. So it's that broad promise which shows up in any number of different specific programs that is driving the system at the moment. Quite a number of things, and they parallel what's going on in the public sector, sometimes exceeding them, sometimes falling a little bit below where the public sector is. So you have a number of bundled payment experiences in the private sector. The most famous is here in Massachusetts with the Blue Cross Blue Shield of Massachusetts Alternative Quality Contract, but you have versions of that going in throughout the country. And then you have a lot of comparative shopping. The idea behind the drugs is if drug A is the same as drug B in effectiveness, don't pay any more for drug B than you're paying for drug A. Well, the private sector has taken that a step further and said, okay, what if surgery from provider A is no more effective than surgery from provider B, but surgery from provider A is twice as expensive? Why don't I just tell provider A I'm only going to pay the provider B rate, or better yet, just send all my patients to provider B? So you've got Lowe's sending all its open heart surgeries to Cleveland. You've got folks in other disciplines saying, okay, look, I want to go to centers of excellence, which folks like Leapfrog and others have been pushing for. I want to see, is your efficiency high? Are your outcomes good? Are your costs low? And if so, we will direct a lot of patients to you. And that's really just an extension of the drugs and a little bit on the imaging. Another way to say it is, what healthcare is trying to figure out is what most other industries have figured out, which is what are commodities and what are services. And you should never buy a commodity from anyone who's not the lowest priced commodity supplier. But for services, you really need to do that. So we're going through, okay, two drugs with exactly the same effectiveness. Maybe they're not services where the doctor has a particular favorite and you've got to cater to that. Maybe those are commodities and we should just look for the cheaper one. And that's really going on across the board, a lot of it in the private sector, and is leading to very big cost savings. Yes, it's partly part of the ACA, which is the ACA required Medicare to go about doing things that would improve the efficiency of the program. But part of it is also the spirit of the ACA is that we need to figure out how to get the system to work better and be more efficient. And different folks are doing that in different ways. We were talking about the payment savings part of it, but another part is giving the information to people so that given their very high cost sharing, they can be better consumers. So you're seeing that with Medicare, where it's publishing the prices that the hospitals charge, not that Medicare pays, but the prices that they charge, the sort of charge master that Stephen Brill was focusing on in his Time magazine article. In Massachusetts, we passed legislation last year that requires insurers by October of 2013, October of this year, to be able to show people in real time what their cost sharing will be and quality would be for any service received at any different provider. You see a lot of firms starting to work with other organizations like Castlight and other kinds of companies that can provide the information to their employees. What they're saying is, you know, I may or may not want to do a very high deductible plan, but I do have very high cost sharing for my employees, and I better figure out how to give them the information they need so that they can use that, so that they're not in my benefits office saying, hey, you've given me this high cost sharing, but now I don't know how to do it, and I'm just totally confused and frustrated by it. Admiral Mike Mullen, when he was the chairman of the Joint Chiefs of Staff of the U.S. military, said that the biggest threat to the United States was the budget deficit, was the budget situation. If you look at the budget situation in the U.S., it is almost entirely a healthcare problem. We don't have a spending problem, we don't have a deficit problem, we have a healthcare problem. So the biggest problems that this country faces, from deficits, from worker productivity and earnings, to wage growth, to anything about the economy, you can't address it unless you run through healthcare. What we know is that the healthcare system is very inefficient, it's spending way too much money, and that's contributing to these problems. What we need to do is to figure out how to make the healthcare system work better. And what a lot of this is about is saying, are we reaching a point where it is working better? If so, how do we encourage that? If not, what do we do differently?